Good morning to everyone who's joining us for this webinar today on policy and health systems to COVID-19. These webinars are under the series COVID-19 Outbreak on the Front Lines, curated by the Harvard T.H. Chan School of Public Health, India Research Center, and Project Sanchar. A brief introduction about the India Research Center. It is the first global center of the Harvard T.H. Chan School of Public Health. Established in 2015, the center has three strategic goals of research, teaching, and translation of evidence into policies and programs. The center provides a platform to facilitate faculty exchange and partnership between public health researchers and Harvard Chan faculty. It is led by Professor K. Vishwanath, who is the Lee Kum-Kee Professor of Health Communications at the Harvard T.H. Chan School of Public Health. Project Sanchar is aimed at building the capacity of journalists to draw on the latest science and data for shaping public knowledge, attitudes, and policy on health. Through this webinar series, the India Research Center and Project Sanchar will host subject experts and leading public health scholars and practitioners to gain an insight into the spread and control of coronavirus, its impact on health and well-being of communities, and India's policy and health system response to mitigate the crisis. So today's webinar, we will look at policy and health systems response to COVID-19. And we are honored to have with us two esteemed guests. I'll start with the introduction of Professor Winnie Yip. She is the Professor of Practice of International Health Policy and Economics at the Harvard T.H. Chan School of Public Health. Her research focuses on the design, implementation, and evaluation of systemic healthcare interventions. She has conducted extensive research on health systems and has worked with the governments and multiple universities in India and China. We are also glad to have with us Mr. Alok Kumar, who is a senior Indian Administrative Service Officer and also an advisor to NITI Aayog, the policy think tank for the government. Alok Kumar, as an advisor for NITI Aayog on healthcare and nutrition for the last 5 years, he holds a BTech degree in electrical engineering from the Indian Institute of Technology, Delhi, and a master's degree in public policy from the Woodrow Wilson School of Princeton University. I will start with you, Professor Yip. You hold multi-country experiences on working on health systems with universities and governments of India as well as China. With this pandemic, what are the similarities and differences that you have seen on how both the countries have tackled COVID?
Thank you very much for inviting me. It's an honor to share some of my experience and also to have a conversation with Alok Kumar. I think that the comparison between China and India is actually not as straightforward because the epidemic started in China at a time when people had very little knowledge about the virus. And for a number of weeks, I think the puzzle at that time was, is the virus being transmitted from animal to human only or from human to human as well? So I think by the time China intervened, the number of cases is already rising at an exponential rate. And so the intervention that China had to do at that time probably would be different in March when India already had known a lot more about the diseases. And I think both countries eventually adopted very stringent lockdown. But I would say that China's strategy is much more centralized, that is directed by the central government, and most of the local places are implementing what the central government designed. And there was also a lot of moving resources from places outside of Wuhan and Hubei to help Hubei and Wuhan. So it's almost a national resource mobilization in a way. And whereas in India, I think India is much more state-oriented, except for the major lockdown decision. I think that the virus, however, has revealed that both countries have some weaknesses in their ongoing healthcare system. I would point out that the first inadequacy in both systems is for infectious disease, Whether we know about the characteristics of the virus or not, the most important thing is to really to localize it, to prevent it to grow exponentially. And that require, before a test is available, is actually to do very early and fast reporting. And that depends on a very good surveillance system. And to be able to identify people who are high risk, quarantine them so that they're not floating around in the community infecting many other people. In other words, you need to contain the number of cases, even in the absence of the specific characteristics, in the absence of a test. And that actually requires good community base, whether it is a community-based social system or community-based healthcare system that would be able to penetrate and to identify cases and to be able to do contact tracing, to monitor quarantine. And so this is what I'm seeing is in both countries, the public health and the primary healthcare system is not really geared up to responding to a challenging virus like COVID-19. And in the future, there will be another virus like this, maybe even more challenging. The other, so I think that's the similarities. And as a result, we see that the hospital is really facing a lot of pressure. And so the question is, can something be done that would prevent the need to have the hospital to face so much pressure? Now, most people would ask me, so should the government then now invest in more hospitals? My answer is always a question mark. If one have to prioritize, I would prioritize investing in the public health system and also the primary healthcare system first. I think in the case of India, and this is my last point, it's a bit tricky because a large part of the outpatient and primary care at this moment is actually in the private sector. So investing is not just investing in the public sector. It almost have to think about how do you invest in a mechanism that would pool resources that would purchase the private sector care with good standard as well. During this outbreak in China, what is impressive is that the private sector really rolled in telemedicine in an extensive scale. And in fact, in the beginning, they provide free care to relieve the burden of people. And that really have taken off a lot of the burden for the non-COVID related care. And I think India really has a great opportunity given all the IT hub that India is being in. And I'll stop here. Thank you.
Well, thank you so much, Professor Yip. We will come to that part about, involving private sector in terms of managing public health crisis. But I will now come to you, Mr. Alok Kumar. 65 days of lockdown, we are slowly unraveling, coming out of lockdown in our own way. This was lockdown, we all knew that was a time to prepare our health infrastructure, prepare the hospital beds, prepare for ICUs, oxygen, ventilators, and all that infrastructure that comes for critical care. What is your assessment? Do you think we have managed to achieve that target of preparing our health systems?
Yeah, I think the lockdown had two purposes. One was preparation and other was also to slow the spread or the infection rate so that your health system is not overwhelmed. Now, clearly, I think mostly you can say for most parts of the country, the health system hasn't been overwhelmed as yet. The doubling rates, which were growing at 3.5 days, doubling rate of new cases, came down to almost 24, 25 days. Now is back to about 16 days, depending on where in the country you are. So in that sense, there were some preparatory aspects also. So for instance, learning from other countries, we tried to create a 3-tier, the primary care, COVID care centers, then COVID health centers, and then COVID hospitals. So that the COVID patients are not mixed with non-COVID patients, because we learned from other places, created a lot of problems to those people who had nothing to do with COVID, but were admitted in wards which were adjacent to COVID patients, and therefore because of the infectiousness. So setting up clinical protocols, how do we handle patients, etc. So there was then preparation of adequate number of isolation beds, quarantine facilities. All these require time to create. And I think I can say with some degree of satisfaction that the time that we bought by the lockdown, even though there are economic consequences that we need to bear, but I think it has given us breathing space to create all these facilities. We'll see in times to come, but as you know, the virus is very much alive. It is going to be alive for the next 1.5 years till such time either is we find a treatment, some drug, something, or we have that vaccine, which we are now, all of us, many nations are chasing, including India. So we have to live with the virus. We cannot be in a perpetual state of lockdown because, as you know, there are economic consequences. We saw some terrible images because of, and the burden falls mostly on the poor. So I think it's a hard place. Decision making in these times is a hard place. You have to choose between two alternatives, both of which are not very pleasant alternatives. So, you are trying to balance these two imperatives, and I think under the circumstances, the government did best what it could. Obviously, hindsight is 20/20 vision, so you can always come back and say, that, oh, you could have done this better. Of course, there is, in any given handling of a situation, you could do some things better. But at this point in time, I think if you look at the case on a per million basis, deaths on a per million basis, I think we have been able to do reasonably well. Any life lost is a life lost. It is sad, and it is our utmost, effort to save as many as possible. But as of now, with the case fatality rates, with the number of deaths, as of now we are okay. But as I said earlier, very little is known about the virus, how it will behave, whether it will strike again. So it's very difficult to say. People, for instance, other countries that have opened up have now started seeing again infections rising. And you see approaches across. Sweden, for instance, did the herd immunity approach. Now you've heard an official admission from them, maybe that was not the right strategy. Lockdown. Now you could argue about stringency of lockdown, how much we should have closed, how much we should have not. But I think under the circumstances, the situation seems to be under control at this point in time.
Right. Okay. I think there is some connection issue with Mr. Alok Kumar, but no problem. Professor Yip will come back to you again. I hope you can hear me well.
Yes.
Okay, great. So we again, from the context of India, when you see, you're seeing that the burden of most COVID cases is being borne by the public health systems, despite the complaints about the infrastructure not being in a great shape. A large number of people in India put their faith on the public health system. However, you've seen that the private healthcare has so far not stepped up to an epidemic crisis. How is it that a country like India, where private health plays a very, very important role, but then we also need public health systems? How do we sort of merge that, or we incentivize the private healthcare to sort of live up to such times?
I think we should separate. I'd like to separate my reply into during a pandemic phase and not during a pandemic phase. During a pandemic phase, I would argue that any health professionals, whether you're public and private, has some professional responsibility to contribute to the health system. Now, of course, professionals also need to have at least some basic level of income to make sure that they're surviving, or an institution will still be surviving. And so then to what extent the government can actually be providing that financial support. But other than that, from a responsibility purpose, even if you're private for profit, during a pandemic time, there is a professional responsibility to contribute. And when it is not during a crisis, pandemic time, then of course there is a just long-lasting debate in India if the government is going to invest more. But I would suggest that, I would just say that I think that this is really a opportune time for the government to think about, is it necessary to invest more in health? Then the question is, do you just invest in the public sector, or do you invest in more of a platform that would purchase care equally from public and private? And I think that would have to be dependent by the state, my view is. And if it is a state of which the public sector is powerful, I mean, is efficient and can deliver, yes, I think you can make a case of that. And so multiple point is who to invest in is which sector can deliver the best service at the lowest cost. So I do think that given India's situation of private sector's presence, there is a need today to start planning about what role they can play, and play in a way that would not impose financial burden on the patients in particular during a pandemic. And you cannot do it at the time when the pandemic is in the midst of it.
Absolutely. Mr. Kumar, again, coming back to you, we've seen that India has invested, India was quick to move on to invest on testing kits. For example, we went on and we purchased kits. We have gone and we have placed orders for PPEs. Our domestic industry has stepped in. So we have made investments in all these ancillary sides of healthcare, but we are still sticking on to tents and stadiums and school halls as a healthcare facility. It's a temporary basis. I know we are doing it for temporary basis, but how is it that this is, as Professor Yip pointed out, this is the best time for us to invest in our healthcare system? Does NITI Aayog have a policy idea on how to sort of invest more on critical healthcare, specifically critical healthcare systems? Let's say if we have a second wave and if we have serious patients coming up, do we have the capacity to treat them? What's your view?
Yeah, so see, Divya, we have as of now about 200,000 cases, and what that means is that almost 80% in our case seem to be asymptomatic, so therefore they don't require any hospital facilities. They might require to stay in home isolation or in quarantine, but they don't require any medical treatment. So that would mean about 40,000 beds by that, and that is spread over a period of 3 to 4 months. So we have about 1.4 million beds or thereabouts, 1.2 million beds total. So by no means is our capacity, at this point in time stretched to a level where, however, because we need to create, you see, many of our urban people are living in very dense conditions. You can't leave them in their home isolation. So unlike, and also we must also understand the per capita economic development of the country vis-a-vis many other countries which you are comparing us with. So for those people, even finding isolation and physical distancing in their home settings is impossible. So some of them will need to be shifted out and into these kind of facilities. So that those are the kind of facilities that we are seeing. It is not because we are running out of hospital beds, but because by design we have to make them move out of their home settings and into an institutional setting, because in their home settings it is almost virtually impossible for them to carry out the social distancing, and then it kind of risks traveling throughout the community through their families. They share, for instance, the same toilets. They use the same stand post for fulfilling their water needs. So please understand that this is not because that you have less number of beds that we are doing that. That is point number one. Point number two is, having said that, it is also true that as a percentage of GDP, what the government spends on health has been almost static for the last 30. It's at the current level, it is 1.13% of the GDP. Now, India is 182nd out of 195 countries that were tracked. So on this metric, so therefore there is a case, and we have always been making a case, the National Health Policy 2017 explicitly makes the case that we should raise it from 1% of GDP to around 2.5%. But this was articulated in 2002. Obviously, as a developing country, there are multiple charges to a particular resource, and the elected political government takes calls. And unfortunately, I would say on this forum, and I can say this, that unfortunately health has not received the priority that it does. So that having said, what we have, if you care to look at, we have brought out a very recently, November last year, we brought out health system for a new India, building blocks, potential pathways to reform, where we argue that yes, there is a need to spend more on health. But having said that, also realize that as a total between public spending and private spending, we end up spending about 4% of our GDP, 3.5 to 4% of our GDP on health, which is not very much, but it is not very insubstantial either. The question is, how do we spend the money? Is it well spent? Is it as efficiently spent? Is it spent out of pocket, which is most inefficient? Or is it spent in a pooled manner where you can efficiently purchase the services? So the point I'm trying to make is, A, there is need for more money. B, even if there is more money, we have to make some strategic choices about our health systems. What is the direction? Do you, like Winnie pointed out, do you want more of strengthening of publicly run systems? Do you want more in purchasing of services? And unfortunately, as a society, we have not given enough thought. There is no political consensus. If you go to a state A, for instance, Assam, there is 80% of the delivery is in the public run facilities. 80 to 85 private sector is very marginal. On the other hand, if you go to a Gujarat or to a Karnataka or to let's say Telangana, there it is the reverse way. 80% of the facilities are delivered through the private sector. So different states have different issues, but as a nation, even as a state governments, we have no articulated way of what those strategic choices are. And unfortunately, if you don't make those choices, you will end up at a default location where you didn't intend to end up. So the point we are making in that volume is, we are presenting a bouquet of options. There are no right options, there are no wrong options. There are different options. Different countries have worked with different kinds of health systems, each of which have some pluses, some minuses. But we need to make strategic choices, we need to make clear choices, and then we proceed accordingly. Health systems are not built in a day, and certainly not during the time of a crisis. That is there's a different response mechanism right now, but at the end of the crisis, there will be a lot of lessons to learn, and therefore a lot of strategic choices to be made. And what we at NITI Aayog are doing is to place these choices before the citizens and the politicians, because they are to take the calls of how do we see our health system going in the next 10 to 15 years. So that is what our goal is. And unfortunately, we see lots of debates on lots of other things, but very little debates on what our health system should be. And that, I think, sometimes pains me, but that is the way it is. We are trying to change that. Hopefully we can change that. But let us see whether COVID gives us sufficient warning and, kind of is the final straw which will start this or trigger this debate.
Absolutely. I mean, thank you, Mr. Kumar. I mean, that was quite a candid admission that health is still not a priority, in many policy debates. And I hope that COVID changes. I don't want to stand between the question, all the audience questions and the panelists here. So I'm going to start taking the questions now. First question for you, Professor Winnie. This is from Sujata Sonik. Could you please throw some light on what to expect going forward? Because we are hearing about second wave, third wave. How can we prepare better for the future, or what lies ahead?
I think that every pandemic and epidemic is both a disaster, but also an opportunity, because I think it is really pushing us to bring into our consciousness some of the limitations that we already are seeing into a much broader light. And so, in fact, I think the more fruitful discussion is in a way more, how do you prepare for the next virus? and situation like that. And again, there are two situations. One is another outbreak of COVID-19 in the future, even if we have a vaccine, for example, that we know more about the characteristics of the disease, versus another one which is like COVID in the first few months. I mean, even now, we still don't know too much about the virus. And the fact that it is asymptomatic just make it so different from SARS, from every other thing. And that's why all the social distancing that every country is imposing with great impact on school, on the economy, etc. So I don't think there is a one cut-out solution that would work, but there are some principles. I would go back to the first principle for any pandemic or epidemic is the country does need to have a strong public health system. It is not the hospital yet, because the public health system is to prevent that you will have to go to the hospital. And I just want to keep emphasizing that.
Sure.
And the second is that I think that the investment in good database is so important. You see at this time that many countries that are better in controlling and preventing the rapid increase of cases tend to have better databases that they can use to tap into and then link with other information to identify travel pattern, to identify history of symptoms from the person, so that while the science is working to discover, you can still call back those suspect cases. And I think with technology now, it is really possible. And I think we need to think a little bit out of the box to think about the technology. Third is, I also see some of the countries that have better response tend to have a system of what they call an emergency command system, an epidemic command system. And at different stage of the disease, you can activate that system to be led by a different person with different power and different executive decision authority that would also be able to coordinate the other sectors, especially when you have an infectious disease. You have to think about the economy, the schools, the transportation system. So those are the few things that I think so far we have learned from other countries as principle.
Sure, sure. Mr. Alok Kumar, next question coming your way. What is, how do you devise a pandemic or an epidemic strategy when you have a federal system?
Well, so we have, fortunately, in the Indian case, the National Disaster Management Act, which provides the basic framework for this. And there is a National Disaster Management Authority, which is in charge, and under the Act, the governments have been empowered to take all these decisions, and the executive decision-making structure is also clearly laid out. Then we also have an Epidemics Act, which is a much older act, which empowers the state governments to take certain actions. And both those pieces of legislation have been invoked in terms of in this particular pandemic. But so these are not the only issues. One is having the legal framework, the other is having the machinery to implement. So we also have a National Center for Disease Control, NCDC, which is leading our effort in terms of the control of pandemic. And then there is a whole paraphernalia around the science, the research, the viral laboratories, which do all kinds of things. And then the whole regulatory piece. So how do you approve a kit, diagnostic kit, others? So while it's called suddenly they were to function at a particular capacity. Now suddenly to handle 1,000 times the workload compressed within 3 to 6 months of response time. So that is when systems start getting overwhelmed, and that is when you need emergency measures to be in place, and you need need to almost work like on a 24/7 emergency basis, quickly taking decisions and so on and so forth. And in the heat of the moment, you take certain decisions. Sometimes they turn out right, sometimes. And please also understand, as Winnie said, a lot of things about this virus is not yet understood properly. So as we know, because China had to face it first, they were the least prepared. And as you got more and more time, countries learned more and more, and therefore, and as I say, countries and states are, kind of refining their responses as we go along. But in terms of the legal framework, we have a reasonable amount of, clarity in this decision making. But then one thing is to have the authority for decision making. The other thing is to get it implemented. So even if, for instance, the decision making at the National Disaster Management Authority takes the decision of a lockdown. Now, if certain states, certain mayors, certain things say that they don't agree, so to build that consensus, you require dialogue. And in these times when everything is locked, you only interact, in some senses, like the way we are interacting right now, building those consensus is a tough act. But I think we have been, there have been differences of approaches. And so if you have a meeting with the chief ministers where 5 chief ministers say one thing, another 15 say another thing, another 10 say another thing, then where do we end up? So there are some gives and takes. There's no perfect decision in this case, but that is how we, in that setup, try to do the best that we can under the circumstances.
Right. Well, thank you. Thank you so much, Mr. Kumar. Again, another question for you, Professor Winnie. How should governments find money to fund their future pandemic responses? You think a COVID tax is perhaps a way to fill up the revenues again that could be used?
So that's a creative question, a COVID tax. It reminds me drawing the parallel of a sugar tax, a cigarette tax. Now, but in those situations, you're taxing someone to not do a bad behavior that would be to reduce the behavior that will lead to bad health. And in the case of COVID, I think that generating additional revenue is always a challenge to any government. But specifically to a COVID tax, the question is, how do you levy the tax? Do you levy the tax on certain behavior? But I think that we're here talking about a tax that actually would put a pot of money aside to prepare rather than to collect it during the time, right? So you cannot collect that tax on people who, let's say, break the rule of social distancing or break the rule of quarantine. If it is a tax that is equally levied, then we know that COVID is actually affecting the poor people a lot more than the rich, then it is regressive. And so perhaps one can levy that tax on behavior of business or the environment if we can find a link that environment is actually causing COVID. So yes, I think that is possible, but putting my economist hat on, one would have to identify what are the causes that we want this group to be paying it for the others because they have contributed to it, and to what extent we do that. I think it's an interesting intellectual question, but would require a lot more analysis.
Sure. Mr. Alok Kumar, just to take that forward, how will India fund its expansion for health? I mean, you have agreed that we are not focusing much on health. What would be NITI Aayog's policy advice to ensure that we find more money in the budget for expanding our health systems?
So, I mean, there are two things. One is how do we find more money for health? But the other question is also, how do we get more health out of the money that we spend on health? Now, if you look at it, we have almost like 1 billion payers. Now, in most countries, Canada, for instance, has 1 payer. There are many other countries which have 4, 5, 6, 10, 13. But you'll rarely find a country which has 1 billion payers. So every household in itself is an insurance company for itself, because largely they fund their own healthcare out of pocket. So 64% of our expenditure is out of pocket expenditure, and much of it is on drugs and outpatient, availing outpatient treatment. Is there a way to better spend the money? Definitely so. Definitely so. So some of it would require thinking about how do you create larger risk pools so that one individual family is not left to the mercy of how it negotiates the health system. The second part which one has to think of is also that 98% of our facilities are less than 10 workers each, which means if you count a bed for 5 workers, which is the global norm, that would mean that 98% of our facilities are less than 2 beds. Now that is not going to be the way forward. So we have a large number of small facilities which are delivering health, and this is also a consequence of the fact because there are individual citizens paying them, individual providers. So we need to really take a strategic view as to whether we want to continue with these many number of providers or we want to continue with these many number of payers. So there are some options, as which I said, which we have presented before, and there are no. I think each one has its own pros and cons. So therefore, you can I'm not pre-specifying that this is what I think is the correct, but you need to kind of think through those options and see what works for you. The last question as to where we can find more money for health, I think that is the more difficult question to answer, particularly at a time when we were thinking our economy, because of this particular shock, is going to find, at least in the short run, difficult to find that money. But somehow or the other, government has found some resources, and they have allocated about 15,000 crores to COVID efforts, and they are now thinking of in terms of additional stimulus to the health sector. So, but these are all catch up. There is a lot of work to be done. Some of it can be thought of in terms of getting contributions from the people, and I think sooner or later we need to start thinking about that, of people's saving. So we have a provident fund, we save for our future. We have many other security schemes. I think there is some of it we have to, some of those kind of new mechanisms have to be thought through to bring more money into health.
Right. So we have exactly now 7 minutes before we wrap this discussion. So Mr. Alok Kumar, you are quite in demand. There is one question that is coming your way. With all the issues that we have seen in private sector, there's been the talk that NITI Aayog is planning to hand over district hospitals to private entities. Is it still a wise decision to go ahead with the plan?
So there is no plan to hand over district hospitals to the private entities. See, the proposal was as follows. If you look at the doctor population ratio, we are 1:1600 or so. WHO recommends a norm of 1:1000. And if you look at the rural-urban skew, although 30% of the population is urban and 70% of the rural, 3 times the doctors reside in urban areas. So you can see that in large parts of our rural India are just starved of the requisite number of doctors. There is therefore a need to expand the supply of medical professionals in general and doctors in particular, even more so specialists than general MBBS doctors. Now, how do you create those doctors? You will obviously require medical colleges. Now, if you look at a private medical college and look at the economics of that, the cost of setting up a medical college, because it requires at least a minimum 300-bedded hospital to be attached with it. It requires about 600 crores to set up a private medical college, a hospital. Now, if they spend then this much amount of money, then they will recover it either from the student or from the patient. Both of you want both the fees to be controlled, and you also want the patient not to be charged much. And the government, because government has spent, almost capped its spending at 1% of GDP for last 30 years. Now, if you don't have investment and if private investment come, then either the cost of education will shoot up, which will then ultimately the doctor will recover from these patients who will come to him. So the question was, can you bring the hospital, because the hospitals of the government have footfalls, they have the requisite number of beds, in any case they are functioning. Can the private sector come in with investment on the educational side? There will be some educational infrastructure which will be required to be created, some labs, some teaching blocks, some hostels, and so on and so forth. And can these two be married so that the hospitals which can train a large number of doctors can also be efficiently used for training doctors? That was the proposal. There was no proposal to hand the district hospital over to the private, as some people have characterized.
Sure, sure. And I think we are running short of time. We just have 4 minutes, and I'm supposed to be doing my conclusions here, but I want to throw back to the panelists here. Quick closing remarks and quick 30-second closing remarks. I'll start with you, Professor Winnie. There is going to be a second wave that perhaps will come. Until a vaccine comes in, we have to deal with COVID. How should we prepare better?
That's a tough question that every one of us is struggling with. I think that to the extent that I do think that we need to listen to science, and at this stage, the scientific knowledge before a vaccine is available, given all the high level of asymptomatic transmission, practicing social distancing, unfortunately, is almost the only way that we know how to do and what to do. And I think as every one of us as a good citizen, we need to think about ourselves, but also the potential impact we have on the people around us. And that's at this point, yes.
Right.
Until we know more about it.
Absolutely. Mr. Kumar, what's your view? What should India do next? We have opened the lockdown. We still have number of cases going up. What next?
So a couple of things. One is that if you look at the Indian situation, the 70% of the deaths and almost the cases are confined to 11 cities. Okay? So it's not as if it is, uniformly spread. We have to see because of some of the migrants returning from these dense urban areas into rural population. We'll see how that plays out in those areas. But as of now, that is the main. And I think the idea there is how you can test more. We have ramped up considerably. Now we are introducing serological tests, at least on a surveillance purpose. ICMR has just done that study. The result should be out. So we will know about what is the general population infection level, and therefore what we can do. And we need to keep on refining our strategies in that sense. But as they say, whatever you do, virus will, has its own mathematics. It has its own way that it will use. There's a lot of effort going on in terms of domestic research, in terms of improving the diagnostics. So for instance, you will be aware that NITI have just discovered the ELISA kits, which is licensed to 6 or 7 domestic manufacturers. So that will make the serological testing fast, quick. And at every district level, we have these ELISA machines which can analyze those samples. So that is there. Work is going on in terms of vaccine discovery. So that is also going on. There are some trials which are taking place. Let us see where we reach with them. On the other side, there's a whole host of work which is going in terms of the clinical protocols of how do we handle, so if the patient lands up, what do we do? What we have seen is that very few patients require, so in the early part of our preparation, ventilators was the thing that we were, kind of concentrating on. Now with our experience, we have learned that perhaps that will not be a constraint because very few patients end up at the well. So oxygen supplies now, oxygen concentrators, oxygen supply are now much more important, and that is now what is being focused on. So what I'm trying to say is that the strategy, there is no one strategy. The strategy is dynamically evolving. As we see, as we get more and more experience, we keep on refining our strategies, and therefore I don't think we will be able to sleep easy for the next 1 year, because this is going to be a consistent battle against this virus. And all of us are in it together. We keep on learning not only from what, and so Kerala did a wonderful job in terms of scaling down and immense learning from that. But they have a certain set of starting conditions which may not be relevant in many other states. Tamil Nadu is doing its own bit. They have reduced their fatality rate is only 0.2%. So they are using pulse oximeters. So there are so many good practices which we are sharing across, and the apex institutions are trying to make sure that all this knowledge is available to everybody. But then, as we say, there are a lot of unknowns. So we'll see how it goes. But I'm confident that we should be able to handle this. We'll come out of it okay. Don't worry.
Okay, we will come out of it okay. That sounds partially reassuring and partly frightening in both ways. But thank you so much for both of you, Professor Winnie. Thank you so much for joining. I think all of us are admiring your background. It's a nice background out there. Mr. Alok Kumar, thank you so much for taking time out. I think there's going to be more questions, of course, beyond these seminars that will be coming your way. So thank you, all of you joining us. This will be recorded. You can catch this session again in a couple of days' time, and keep a watch on the next session that will be coming from the India Center. Thank you.
Thank you. And nice seeing you, Alok.
Thanks, Winnie. Always a pleasure seeing you.